Hi everyone, and thanks for watching my presentation for the ICS online conference of 2021. My name is Teeuwen and I am a master's student at Maastricht University. And during this presentation, I will elaborate on our research on unraveling the mechanisms of interoceptive processing in OAB, during which we continuously monitored patient-reported bladder sensation during a bladder filling protocol. These are our conflicts of interest. So the human urinary bladder has two phases, namely the storage and the emptying phase. And how we switch between these phases is done through interoceptive processing. Interoceptive processing is the assessment of the physical state of the body, and for bladder sensations, this can be done through bladder fullness and urgency. From a neural perspective, this means that during the storage phase, visceral sensory information is relayed from the bladder through the spinal cord to the brainstem and from there on out to higher brain areas. And in these higher brain areas, the bladder sensations are processed and our attention is shifted to our bladder when needed. A brainstem structure that is known to be involved in controlled micturition and interoceptive processing of bladder sensations is the periaqueductal gray, or the PAG. And because of its very central location in the cycle, it functions as a relay station and a gatekeeper. So optimal functioning of these central control systems is needed to accurately assess bladder fullness sensation and urgency. And in case these control systems fail to accurately assess bladder sensations, it can lead to conditions like overactive bladder syndrome, or OAB. And the ICS defines OAB as urgency with or without urge incontinence, usually paired with frequency and nocturia. And over the past couple of years, it has become apparent that OAB is associated with altered bladder sensations. Recent neuroimaging work has reported that the PAG reflects subjective reported bladder sensations, and therefore PAG might actually offer insight into interoceptive processing, and which could help us identify alterations in interoceptive processing causing these false alarms in OAB. During this study, we conducted a bladder filling protocol, for which we inserted a filling catheter transurethral, and the bladder was filled with a saline solution at 30 milliliters per minute using a syringe pump. We did this on 4 healthy females and 3 females with an overactive bladder. And during the bladder filling protocol, we asked all participants to continuously report their bladder fullness sensation and urgency. The bladder fullness sensation was reported on a VAS scale from 0 to 100, and the urgency was reported on the 4-point EOS scale. We propose that bladder fullness sensation and urgency are 2 independent processes, and they are both needed for proper functioning of the lower urinary tract. We also expect that bladder fullness follows a linear trend with bladder filling, and urgency follows a non-linear trend with bladder filling. As for the results, when looking at bladder fullness sensation, it does seem to follow a linear trend for both OAB and healthy participants. However, when we tried fitting a line or sigmoid function to the urgency reports, we found that this was not possible due to the 4-point scale that we used. However, urgency does not seem to follow a linear trend, and therefore further investigation is needed to determine the exact relationship between bladder volume and urgency. So, bladder fullness sensation does follow a linear trend in both OAB patients and healthy participants, which indicates that both groups are able to accurately assess increases in bladder volume. Urgency does not seem to follow a linear trend upon visual inspection for both OAB patients and healthy participants. We found that previous research had assessed urgency sensations on a VAS scale during a water loading protocol, and they observed the increase of urgency to follow a convex or sigmoid trend. And we actually expect to see a similar trend when we change the 4-point ES scale to a full range VAS scale. This way we can accurately assess the trend urgency follows with bladder volume. Both these analyses could help identify disparities between bladder fullness and urgency in OAB patients, but also between OAB patients and healthy participants, which would be of great value to the patients themselves, of course, and the clinicians, as this leads to a more personalized treatment approach. We do acknowledge the small sample size. However, it does support our hypothesis that bladder fullness sensation and urgency are two independent interoceptive processes. And we expect this to be reflected in the central nervous system visceral sensory information. And therefore, we want to integrate this bladder filling protocol with neuroimaging to create an even better understanding of the underlying mechanisms of interoceptive processing of bladder sensations, especially in the PAG. So the difference in the extent to which bladder fullness and urgency show a linear relationship with bladder filling really indicates that there are two different interoceptive processes at play here. And to further investigate the underlying mechanism of interoceptive processing related to these false alarms created in OAB patients, integration with neuroimaging studies is needed, as this will help us broaden our understanding on interoceptive processing in the central nervous system. This enables us to streamline diagnostic and treatment strategies towards a more personalized treatment approach, and ideally to a improved quality of life for the patients. I would like to thank you all for the interest in my presentation and our research, and would love to answer any questions. And these are the references we used in this abstract.